Welcome to the funnel effect. Today, we are opening the door to the left side of the human heart, but not through a scalpel. No, through a tiny, specialized needle. We're taking a deep dive into one of the most fundamental yet, let's face it, high-stakes access procedures in modern interventional cardiology, transseptal puncture, or TSP. This is that delicate keyhole maneuver that really makes complex structural heart repairs and electrical treatments possible. Our source for this exploration is the Exhaustis 2021 review, Transseptal Puncture, Procedural Guidance, Challenging Situations and Management of Complications, penned by Giulio Russo, Maurizio Taramasso, and Francesca Maisano. It was published in Euro Intervention. So the mission for this deep dive is to understand the incredible precision required here. TSP is, well, it's the foundational access point to the heart's high-pressure side, but it's far more than just poking a hole. We need to unpack the meticulous planning, the layers of specialized equipment, the multimodal imaging requirements, and crucially, the immediate life-saving emergency playbook that operators must have absolutely mastered.
Yeah, this is a critical topic for anyone involved in structural cardiology. I mean, the success of major interventions, from fixing a leaky valve to closing an appendage, it really hinges entirely on the quality and location of this initial puncture. We aren't just looking at how they cross the septum, but the critical distinction between the ideal sort of centimeter-precise target and the surrounding danger zone. This deep dive should offer you a shortcut to appreciating why this tricky procedure demands the level of meticulous planning that makes it safe and successful. It's really an intellectual journey into extreme physiological engineering.
It is always fascinating to look at how medical procedures evolve, isn't it? TSP was introduced way back in the late 1950s by Dr. Ross and his colleagues, but initially it served an entirely different purpose than it does today.
It absolutely did. Yeah, the procedure was born out of diagnostic necessity, really. Back in the 1950s, doctors had, limited ways to accurately assess the pressure within the left atrium. They needed precise measurements to properly select patients for cardiac valve surgery. TSP was revolutionary then because it gave them direct, reliable, and relatively safe access to the left side of the heart to, gather that pressure data. It was purely a gateway for information back then.
Right. But our source makes it abundantly clear that the diagnostic use of the procedure has almost disappeared today, hasn't it? Thanks to non-invasive imaging like MRI and sophisticated echocardiography. Yet, the overall volume of TSP procedures has absolutely skyrocketed. So what caused that massive shift?
Well, the shift came entirely with the dawn of interventional cardiology. As technology allowed us to transition from open chest surgery to treating complex heart issues using catheters delivered through blood vessels, we suddenly needed a reliable, high-precision path to the left atrium. The mitral valve, the left atrial appendage, the pulmonary veins, all these critical structures are now routinely accessed with catheters, and the interatrial septum is really the only clean path. So TSP is now the key to executing these percutaneous interventions.
Let's maybe list some of those procedures. For you listening, this is the so what moment, why TSP is so central to modern practice.
Okay, yeah. The list really demonstrates just how foundational this access is. We're talking about complex electrophysiology ablations, particularly those targeting atrial fibrillation that originate in the pulmonary veins, which sit on the left side. Then you have the major structural heart repairs. Percutaneous mitral valve repair or implantation, which covers huge procedures like MitraClip or transcatheter mitral valve implantation, TMVI.
That's already high-stakes stuff, but there's even more.
Oh, yes. TSP is also used for closing patent foramen or PFO, which is essentially a remnant hole in the septum. It's necessary for left atrial appendage, or LAA, occlusion, often performed to prevent stroke in high-risk patients. It's even used for smaller but vital repairs, like fixing leaks around artificial valves, that's paraprosthetic valve leak repair, and for positioning components of left ventricular assist devices, or LVDs. It is effectively the delivery entrance for complex tools into the left side of the heart.
That list definitely underscores the absolute necessity of safety and precision. But here's the core difficulty highlighted in the source material. Unlike accessing the right side of the heart or dealing with major vessels where you might rely on, say, calcification or bony landmarks visible under X-ray, the atrial septum itself is soft tissue.
Precisely. That's the key challenge. The structures we're targeting, the thin, fibrous tissue of the fossa ovalis, are completely invisible under standard fluoroscopy alone. The only thing in fluoroscopy, the X-ray C-arm shows you is the metal hardware, the catheters, the guide wires, the BRK needle itself.
Okay, so if the target tissue is invisible under fluoroscopy, why not just rely solely on T, the transesophageal echocardiography? Why is fluoroscopy still essential, even when you have this high-tech guidance?
That's a really critical question, and it speaks to the synergy required between the two. Fluoroscopy is essential because it allows the operator to track the hardware in relation to the overall thoracic anatomy. They need to see where the sheaths and needles are located relative to the spine and, say, the aortic root. But ET gives the soft tissue detail. T is the non-negotiable partner because it provides that real-time visualization of the septum's bowing or tenting as the needle approaches. It ensures the operator is entering the left atrium safely, accurately, and most importantly, exactly where the device needs to be deployed. Without T, the procedure honestly reverts to being high-risk guesswork.
Okay, let's transition into the tools that execute this precision maneuver.
Yeah.
If TSP is the foundation, the Brockenbrew or BRK needle is, well, the historical cornerstone. The source gives fantastic detail on its construction.
Yeah, the BRK needle is a neat piece of minimalist engineering. It's stainless steel, but what's really crucial is the internal stylet. When the operator advances the needle through the sheath and dilator, that stylet fills the central lumen. If it weren't there, the friction between the two long metal components could make the motion jerky, unpredictable, and frankly dangerous. The stylet ensures smooth, controlled advancement, and the actual piercing tip is reduced in caliber from 18 gauge down to a finer 21 gauge, which helps minimize trauma when crossing the tissue.
And these needles aren't one-size-fits-all, are they? There are specific versions tailored to the patient's anatomy or maybe the difficulty of the access route.
Exactly right. The standard BRK needle has a fairly gentle 19-degree angle at the tip. But if the anatomy is complex, perhaps a highly enlarged right atrium or a challenging SVC approach, the operator might need the BRK1. That one features a much steeper 53-degree angle. This sharper angle gives the operator more mechanical leverage to direct the tip precisely onto the fossa ovalis. It also allows the operator to hand-shape the curve of the entire needle assembly, to match the unique curvature of the patient's vasculature leading up to the right atrium.
Right. Beyond the needle, we need the guiding sheaths. The source contrasts the Mullins sheath with the Swartz braided superior left, or SL sheath. What's the functional difference between these two standard bearers?
They're generally chosen based on the required stability and maneuverability for the specific procedure. The Mullins sheath has an established, predictable curve. It's often the default choice because that curve is specifically designed to point toward the mitral valve area, which simplifies the standard approach.
And the Swartz SL. Why would an operator opt for a braided sheath? What does that give them?
The braided construction of the Swartz SL is key. Braiding the material significantly enhances two critical properties: pushability and torqueability. Pushability means that when the operator pushes from the groin, the force is transmitted efficiently to the tip without the sheath kinking or buckling. Torqueability means that when they twist the proximal end, the tip of the sheath rotates immediately and accurately. One-to-one rotation, basically.
Can you give us a scenario where that superior torqueability of the Swartz SL might prevent a failure or make things easier?
Sure. Consider a patient with a highly tortuous or perhaps calcified superior vena cava, a very nonlinear path from the groin to the heart. If the sheath is too floppy, the tip might not point correctly toward the septum, or it might accidentally snag on the atrial free wall. The high torqueability of the braided SL sheath allows the operator to perform these really fine micro-adjustments and maintain the tip's exact orientation, often targeting the superior left pulmonary vein, which is necessary for certain device placements. They are also available in large bores, 8 up to 12 French, to accommodate the increasingly complex and large devices used today.
This level of detail really confirms that preparation truly is half the battle here. Let's talk about the blueprint, the pre-procedural imaging and mapping. T is the requirement during the procedure, but what vital information must it provide beforehand?
Well, pre-procedural T is mandated for all patients undergoing TSP. It's the initial anatomical survey. It gives critical insights into the interatrial septum anatomy. It helps identify congenital features like a patent foramen ovale, PFO, any atrial septal defects, ASDs, or maybe existing patches and scar tissue from previous surgeries. That helps define whether they'll need a specialized needle. And most importantly, the T detects absolute contraindications, primarily a left atrial thrombus, a clot, or any atrial tumors. Both of those would instantly abort the procedure due to the massive risk of embolism.
Got it. And CT plays a more specialized role, usually only used when the structural intervention is particularly complex, like TMVI.
That's right. CT adds a layer of three-dimensional precision that standard 2D echo often can't match. It's pretty much necessary for transcatheter mitral valve implantation, TMVI, because you are placing a very large device that fundamentally changes the cardiac anatomy. The CT data provides highly specific measurements, assessing the aortic mitral valve angle, predicting the neo-left ventricle outflow tract, which is critical for preventing LVOT obstruction after the valve is placed, and measuring the exact distance between the annulus and the coronary vessels. You absolutely must ensure the new valve won't pinch off the coronaries.
The aha moment here, and something that really elevates modern practice, seems to be the translation of the CT data into a kind of virtual rehearsal.
This is truly state-of-the-art stuff. Specialized planning software takes the multi-slice CT images and uses them to create a full virtual simulation of the patient's heart. The software maps out the ideal C-arm orientation, the necessary height of the puncture from the valve plane, and the exact catheter orientation needed to align the TST system perfectly with the fossa ovalis. The operator can literally practice the trajectory and ensure the target zone is achievable before the patient is even prepped and on the table. This moves the procedure from purely real-time intraprocedural judgment towards a pre-planned, optimized trajectory, drastically improving predictability.
Okay, so with the preparation and tools sorted, let's precisely define the target. The authors make a crucial distinction between the full anatomical interatrial septum, IS, and the true IS. Why is this distinction so vital for safety?
Ah, yes. The anatomical septum is the entire wall dividing the two atria, but most of that wall is actually thick muscular tissue. If you puncture through the muscle, you risk severe bleeding or creating an unmanageable defect. The true IS, which is the safe crossing zone, is the much thinner membranous section that developed from the embryonic foramen oval. This safe area, essentially the fossa ovalis, accounts for only about 20% of the total septal area, so the operator must aim specifically for this thin, pliable tissue.
And what happens if the operator misses that 20% sweet spot? What are the dangers?
Well, the dangers are immediate and severe. If you puncture too far anteriorly and superiorly, you risk entering the aortic root, a catastrophe. If you go too far posteriorly and superiorly, you can inadvertently breach the left atrial free wall and enter the pericardial space. That's the direct cause of cardiac tamponade. The fossa ovalis, located in the lower posterior part of the IS, is the path of least resistance because it's composed of only thin fibrous tissue. That's the target. And to help navigate this relatively small 20% zone, the fossa is often schematically divided into 4 quadrants: superior anterior, superior posterior, and inferior posterior. The choice of quadrant isn't random at all. It's dictated entirely by the end goal of the intervention. Posterior punctures are typically for mitral valve work, anterior punctures for certain annuloplasties, and so on.
Before any hardware reaches the septum, though, we need access. The source strongly favors a specific vascular route and technique for insertion.
Yes, the right-sided venous femoral puncture is overwhelmingly preferred. The anatomical reason is quite simple. It offers the most direct linear trajectory to the right atrium, RA, and thus the septum. A left-sided approach introduces more tortuosity and is usually reserved only as a backup if the right side fails or is inaccessible. Minimizing turns and twists is really paramount for sheath stability and control.
And the physical location of the puncture in the groin itself is a major safety consideration, specifically advocating for a low puncture. Why low?
Right. This is a fantastic tips and tricks point from the source for technical success. They advise a low puncture just a few centimeters below the inguinal ligament. Why? Because at this low point, the femoral vein is typically a large, substantial vessel that hasn't yet branched or bifurcated significantly. Puncturing high, closer to the ligament, is more dangerous because the vein might be smaller there, and it's often covered by more abdominal tissue. This significantly increases the risk of a serious, difficult-to-manage retroperitoneal bleeding event if you inadvertently puncture posteriorly.
What guidance ensures they hit the mark accurately down there?
Ultrasound guidance is strongly suggested, ideally, as it allows for real-time visualization of both the artery and the vein, letting the operator target the vein precisely while avoiding the artery. But if only fluoroscopy is available, the landmark is the femoral head in the anteroposterior AP projection. The needle should be positioned medial to the femoral head and below its equator. The goal always is to avoid accidentally puncturing the adjacent higher pressure femoral artery.
And immediately after securing venous access, the first pharmacological step occurs: early anticoagulation. Why so early?
Yes, this is an important procedural safeguard. The standard instruction is to administer approximately 2,000 units of heparin right after the vascular access is confirmed. Since the TSP maneuver itself can sometimes be challenging, complex, and potentially time-consuming, this early dose is crucial to prevent device thrombosis. You don't want clots forming on the long sheaths and catheters while the operator is busy navigating up the septum. This just ensures the hardware stays slick and safe throughout the initial phase.
Okay, we have the patient prepped, The access secured, the blueprint finalized. Now we are inside the heart. Let's walk through the 5 critical steps of the transseptal puncture sequence itself. Step 1. Advancing the assembly.
Right, so the entire assembly, the sheath, the dilator inside it, and usually a guide wire, is advanced smoothly from the femoral vein. It's tracked all the way up into the superior vena cava, the SVC. Both TEE, typically in the bicaval view, and fluoroscopy in the AP projection are used simultaneously to watch this happen. A crucial safety point here, emphasized by the authors, is ensuring the sheath tip faces slightly leftward, towards the aorta on fluoro. If it faces right, there is a risk of snagging on the right caval-free wall, which could damage the vessel or interfere with existing pacemaker or defibrillator leads if they're present. You might need to position posterior to those leads.
Okay. Step 2 is managing the BRK needle insertion itself.
Right. The BRK needle is inserted into the back of the sheath, with the stylet still in place to ensure smooth passage through the sheath's lumen. The needle is only advanced until it is about, say, 4 centimeters back from the tip of the sheath dilator assembly. This protects the sharp needle tip during navigation up the veins. Once the stylet is removed, the needle hub is immediately connected to a pressure monitoring line. This is absolutely crucial. It allows the operator to constantly read the pressure right at the tip, which is a primary check for safety later on.
Step 3 is arguably the most delicate part, the critical pullback and tenting maneuver where the operator is actually searching for the fossa ovalis.
This is where the real skill and feel come into play. The operator starts pulling the entire assembly back slowly from the high SVC position. The needle arrow, which indicates the direction of the curve on the handle, is pointed either at 5 or 6 o'clock on an imaginary clock face. 6 o'clock is the position generally used when aiming for a more posterior puncture, which is usually the requirement for most structural interventions, like mitral repair. The system is pulled back steadily until the tip literally pops or drops into the depression of the fossa ovalis. You can sometimes feel the subtle change.
What mechanical and physiological feedback confirms that the system is correctly resting on the thin fossa? How do they know they're there?
Well, TE, primarily in the bicable view, is constantly monitoring this. You will see the characteristic tenting of the septum, the thin, fibrous tissue bowing inward towards the left atrium under the gentle pressure of the needle tip. Interestingly, the source notes a specific physiological marker. As the needle presses against the superior rim of the fossa, patients often experience supraventricular extrasystolic beats, just brief, irregular heart rhythms. This is a subtle yet recognized sign that the tip is correctly engaged right at the edge of the fossa. The operator must then be careful not to pull back too far and accidentally fall down into the inferior vena cava. Fluoroscopy helps prevent that overshoot downwards.
Right. Once tenting is confirmed, the procedure shifts immediately to step 4, securing the correct height and location. This is entirely dictated by the device they plan to introduce eventually. This seems like the ultimate point of precision planning.
It really is the moment where all that pre-planning meets execution. The T view typically switches to the short axis, SAX, at the base view to confirm the posterior location of the tenting point relative to the aorta. Then, crucially, in the 4-chamber view, they measure the puncture height. That's the vertical distance between the tenting site on the septum and the plane of the mitral annulus. If this distance is wrong, the final large delivery catheter will simply not align correctly with the valve later on.
Let's elaborate on those critical distance requirements you mentioned for mitral interventions. We hear 4 centimeters for degenerative MR and maybe 3 centimeters for functional MR.
Why?
What's the difference?
Yeah, that difference is driven by the underlying disease and the mechanics of the devices, like the MitraClip system. Degenerative mitral regurgitation, MR, usually involves floppy, complex valve leaflets, often requiring a larger or maybe multiple clips. This demands a wider, more stable access path and generally a steeper angle of approach from the septum down to the valve. If the puncture is too close to the annulus, less than 4 centimeters, the large delivery sheath can impinge or conflict with the valve structure itself, making the device very difficult to maneuver and deploy accurately. Functional MR often involves a structurally normal valve just being pulled apart by changes in the ventricle. Sometimes this requires a slightly less extreme angle, allowing a slightly closer puncture distance, maybe around 3 centimeters.
Okay, so height is critical. Location within the fossa is equally critical then. Where do you need to be for a MitraClip versus, say, an LAA occlusion versus something like a cardioband annuloplasty?
Absolutely. MitraClip generally demands posterior punctures, either superior posterior or inferior posterior quadrant, because the catheter needs to approach the mitral valve from the back, effectively, to grasp the leaflets correctly. Conversely, if the operator is planning a cardioband procedure, which is a direct annuloplasty device placed on the valve ring, they usually need a more anterior puncture site for better alignment with the annulus itself. And for left atrial appendage, LAA occlusion, they generally aim for a more inferior location within the fossa to gain the most direct access down into the appendage itself.
Fascinating. If the initial tenting is, say, 1 centimeter too low, how does the operator precisely adjust this height without moving the entire system wildly and losing position?
They adjust by gently rotating the entire needle and sheath assembly together as one unit. This is a subtle mechanical adjustment. Clockwise rotation of the assembly typically moves the tip superiorly, away from the mitral valve plane, which increases the height. Counterclockwise rotation brings the tip inferiorly, closer to the mitral valve. The operator must rotate concordantly, ensuring the needle's arrow indicator and the sheath tip move together, maintaining stable contact with the septum throughout the adjustment.
Okay. Step 5 is the actual puncture and the ultimate safety confirmations, the real moment of truth.
Right. The puncture itself should be a slow, controlled forward advancement of the needle only, while the sheath and dilator are held absolutely steady, maintaining that precise alignment. TE in this SX view confirms a subtle release of the tenting. You see the septum snap back slightly, confirming the needle tip has crossed the fossa into the left atrium. But the procedure absolutely doesn't stop there. The source stresses the non-negotiable safety measure, what they call the quadruple check.
That sounds like a protocol specifically designed to prevent catastrophic error. What are the 4 indicators that must be verified before advancing anything further?
The sheath must never be advanced until all 4 of these checks are confirmed positive. 1. Clear T confirmation of the needle tip crossing into the left atrium space. 2. Successful blood aspiration through the needle. The blood should be bright red, arterialized, confirming it's the high oxygenated blood of the LA. 3. Verification of the pressure curve via the connected pressure line. The pressure trace must clearly show left atrial pressure, which is typically low and has characteristic A and V waves. This check is paramount. If the pressure is high and pulsatile, like the aorta or ventricle, they've punctured the wrong structure, and that is an immediate emergency. And 4. A small contrast injection, a puff, performed under fluoroscopy, confirms the contrast swirls freely within the LA cavity and rules out any accidental entry into the pericardium or a great vessel.
Wow, that sequential validation process is intense but clearly necessary. Once they pass the quadruple check, what is the next immediate step?
Immediately following that confirmation, full systemic heparinization is administered, usually 100 units per kilogram of body weight, aiming for an activated clotting time, ACT, of 250 to 300 seconds. This therapeutic anticoagulation ensures the devices and sheaths subsequently placed in the left heart won't promote thrombus formation on that high-pressure side.
And finally, the sheath itself can be advanced.
Correct. The sheath is advanced over the dilator, still under TE guidance, just 1 to 2 centimeters into the LA cavity, avoiding deep penetration that could irritate the LA wall. The needle and dilator are then carefully retrieved. A stiff guide wire is then usually placed, typically lodged safely into the superior left pulmonary vein. This often requires a slight clockwise rotation of the sheath to direct the wire away from the LA opening. Oh, and one final point the source mentions, particularly for large procedures like TMVI. Since the final delivery devices are massive, they often require subsequent septal dilatation using a peripheral balloon, sometimes 12 to 16 millimeters in diameter, just to safely accommodate the large bore sheaths needed for the valve delivery.
We've detailed the process for a relatively normal flexible septum. But what happens when the tissue is resistant, maybe scarred or heavily calcified? Perhaps due to previous cardiac surgery or radiation therapy. Forcing a standard needle through that seems incredibly risky.
It is extremely risky, yeah. The fundamental danger here is what's known as the overshoot phenomenon. If the operator applies excessive increasing force trying to push the standard BRK needle through thick, resistant tissue, tension builds up in the system. When the penetration finally occurs, that stored potential energy is released suddenly, causing the entire system needle, dilator, and sheath to jump forward or overshoot. This can potentially lead to puncture of the contralateral wall of the LA or even the posterior aorta, a really bad outcome.
So specialized tools are necessary then to replace brute force with more controlled penetration. What are some of the modern alternatives for getting through tough septa?
Right. The source outlines several key strategies. For slightly thickened septa, sometimes a simple technique works. Using the stiff back end of a small 0.014-inch coronary angioplasty wire pushed through the needle to create a small initial perforation. A second method, often used in conjunction with the standard BRK needle, is applying controlled radiofrequency, RF energy, to the proximal, uninsulated part of the needle using a standard electrosurgical cautery generator, like a bovie pencil. This slightly heats the needle tip, aiding penetration without excessive force.
And then there are the dedicated devices designed specifically to eliminate that overshoot risk entirely. Right.
Absolutely. One key example is the safe sept needle-free NF guide wire. This is actually a nitinol wire with a very sharp tip that is designed to create the initial puncture without needing a traditional needle at all. Its crucial safety feature is that once the tip passes through the septum and it loses the support of the surrounding dilator and sheath, its nitinol material properties cause the tip to automatically assume a pre-shaped blunt J curve. This immediately renders the tip incapable of further tissue penetration, effectively stopping any potential overshoot dead in its tracks. It's quite clever.
And the ultimate control mechanism for the toughest cases seems to be the dedicated Baylis RF Transseptal system.
Yeah, the Baylis NRG system essentially replaces the standard mechanical BRK needle entirely with a dedicated RF energy delivery catheter. Instead of relying on mechanical force, it uses small, precise bursts of radio frequency energy, typically around 5 watts for just 2 to 5 seconds at a time. This tiny burst of focused energy is usually enough to cleanly perforate even the toughest, most scarred septum after just 1 to maybe 4 pulses. The beauty of RF technology is that the penetration is incredibly clean and controlled, making it the most effective tool we have to prevent that dangerous overshoot phenomenon that traditional mechanical needles really struggle with in resistant tissue.
Beyond thickness, variable anatomy can pose complex challenges too. You mentioned enlarged atria earlier. How does that change the game?
Right. If either the right or the left atrium is severely enlarged, the overall geometry of the heart changes significantly. The TSP generally must be performed more inferiorly and perhaps less posteriorly than usual. Why? Because if the puncture is too posterior in a very enlarged left atrium, the actual distance between the septum and the posterior left atrial free wall can decrease dramatically. Puncturing too far back in that situation significantly increases the risk of accidentally exiting the LA free wall and entering the pericardial space, a direct route to tamponade.
And what about a floppy septum? That seems counterintuitive. It's thin, maybe easier to puncture, but still challenging.
Yeah, a floppy septum presents stability problems later on. Because it's so flexible, when the operator starts steering large, relatively stiff delivery catheters through the access hole created by the puncture, the septum itself can be easily pushed around or distorted. This can actually cause the effective height of the puncture site relative to the mitral valve to decrease during the procedure, moving the access point perilously close to the mitral valve structure. In these specific cases, the authors sometimes recommend deliberately aiming for slightly higher initial punctures or leveraging the enhanced precision and stability offered by RF systems to ensure that the access hole remains stable and correctly positioned throughout the often long and complex intervention that follows.
Okay, let's look toward the future of guidance for a moment. Fusion imaging. The concept of merging T and fluoroscopy in real time sounds like it should be the ultimate end goal of procedural guidance.
It's conceptually brilliant, definitely, and visually very impressive. Systems like Philips Echo Navigator or Siemens TreeFusion take the live fluoroscopic X-ray image and digitally overlay it with the bi- or even three-dimensional T datasets. The goal is to merge the strengths of both modalities onto a single monitor for the operator.
What exactly are those combined strengths that Fusion tries to leverage?
Well, T provides that unparalleled visualization of soft tissue structures. The septum itself, the valve leaflets, the target zone on the fossa ovalis. Fluoroscopy, on the other hand, provides excellent visualization of the metal hardware, the catheters, the guide wires, the devices being manipulated. By integrating them, fusion imaging theoretically simplifies eye-hand coordination, allowing the operator to see the metal device moving through the visualized soft tissue anatomy in one unified image. It can even superimpose the pre-planned ideal location of the fossa ovalis onto the live fluoroscopic image, potentially helping predetermine the optimal C-arm angulation before you even start.
That sounds like an unmitigated benefit, really. But you mentioned the source injects a dose of realism, noting several limitations in current practice. What are they?
Yes, the limitations are quite practical at the moment. One issue mentioned is the sheer volume of visual information on the screen. The visual clutter can actually be distracting for some operators, leading to what some jokingly call fusion or confusion. Another practical hurdle is the often proprietary nature of these systems. The echo machine and the angiography system frequently must be manufactured by the same company to allow them to talk to each other seamlessly for the fusion overlay to work.
But the most significant technical hurdle probably relates to the heart's motion itself, doesn't it?
Correct, that's a big one. The heart is a dynamic, constantly moving organ. While the target markers or anatomical overlays are mapped from a static CT scan or a T image captured at one point in time, they don't always perfectly follow the heart's complex motion during the respiratory cycle and the cardiac cycle. This can introduce subtle but potentially significant inaccuracies. If the displayed planned puncture site is off by even a few millimeters due to this motion artifact or registration error, it can negate the potential benefit of the visual overlay.
And in terms of hard outcomes, like procedural time or complication rates, has fusion imaging definitively proven its superiority yet in TSP?
Not really, not definitively, according to this review. The authors note that while it certainly enhances visualization and planning capability, the current clinical data has not yet demonstrated solid, consistent advantages in terms of significantly reducing procedural time, radiation exposure, or actual complication rates compared to a skilled operator using standard, meticulous TE-guided TSP technique. So it remains a powerful tool, especially for complex cases or training, but its routine clinical utility and cost effectiveness are still evolving and being actively studied.
In a procedure defined by such high stakes and proximity to critical structures, the complication management protocol is obviously just as vital as the procedure itself. Let's start with pericardial tamponade, the big risk often associated with a posterior puncture.
Right. Pericardial tamponade is probably the most feared and potentially most direct complication of TSP. As we discussed, if the puncture is performed too far posteriorly, near the border where the thin fossa meets the thicker muscular septum, the needle, or more significantly, the sheath can inadvertently cross the left atrial free wall and enter the pericardial space. This causes bleeding into the sac around the heart, leading to rapid pressure buildup and cardiac compromise. That's tamponade. It can be immediate or sometimes delayed. TE is the primary tool used to rapidly diagnose the resulting atrial hematoma and the pericardial effusion.
What is the management protocol the source mandates if tamponade occurs?
The first immediate treatment is always emergent pericardial drainage, pericardiocentesis, to relieve the pressure and stabilize the patient hemodynamically. After stabilization, the breach in the atrial wall must usually be closed, often using a small septal occluder device, like an ASD closure device, deployed across the injury site from within the atrium. The authors offer a really critical practical tip here for minimizing time lost if this occurs. They advise keeping a guide wire parked across the septum after removing the main interventional catheter from the LA, and then monitoring the patient closely with T for a few minutes before pulling everything. This simple step allows for immediate, easy re-access to the left atrium if bleeding or effusion is detected shortly after, saving precious, potentially life-saving minutes in reestablishing access for closure.
Okay. On the opposite side of the spectrum, anatomically speaking, is the risk of aortic puncture, a rare but potentially catastrophic event.
Yes, this is extremely uncommon when T guidance is used meticulously, estimated at less than 0.1% of cases in experienced hands. It occurs almost exclusively during procedures that specifically require a very anterior puncture site, or perhaps in patients with very complex or distorted anatomy, for instance, a patient with severe aortic root dilation where the aorta bulges close to the septum.
If the operator suspects or confirms an aortic puncture, what is the single non-negotiable instruction from the source?
Do not pull back anything. That is the absolute, critical, four-word safety protocol. Freeze. If the dilator and sheath have advanced into the high-pressure aorta, they are, in effect, temporarily plugging the hole they just created. Pulling them back would instantly cause massive, likely fatal hemorrhage into the pericardium. The operator must freeze the equipment in place and immediately summon a cardiac surgeon. Now, if only the fine needle tip has advanced, the consequences might be minimal, maybe just a small hematoma. But if the larger dilator and sheath advance, the result is potentially massive, life-threatening hemopericardium. Interestingly, the source notes that in recent years, transcatheter techniques for aortic puncture closure using specialized occluder devices delivered through the existing sheath itself have been described as a potentially successful and rapid way to fix this complication without requiring open surgery in some cases.
We also discussed a very different type of complication earlier, one that is more electrical and nervous system related, ST segment elevation on the ECG.
Ah, yes. This is a fascinating physiological response that can occur during septal manipulation. It's often attributed to the basal Jerish-like reflex. Clinically, it presents as ST segment elevation on the ECG, typically seen in the inferior leads, but crucially, it is usually accompanied by profound vagal symptoms. Sudden, severe hypotension, low blood pressure, marked bradycardia, slow heart rate, and sometimes profuse sweating or diaphoresis. The theory is that the high density of parasympathetic nerve fibers located within the interatrial septum reacts quite dramatically to the mechanical irritation of the puncture or catheter manipulation, leading to a surge in cholinergic activity and subsequent coronary vasospasm.
Wait, so the ST elevation that looks like a heart attack isn't actually myocardial ischemia in this case? It's essentially nervous system shock response. How do they confirm that in real time to avoid misdiagnosing a true MI?
Exactly. It perfectly mimics an acute heart attack on the monitor, but it's thought to be primarily a nervous system overdrive. The key clinical clues to confirming it's likely the reflex are twofold. First, the simultaneous presence of those profound vagal symptoms, the bradycardia, the hypotension, which aren't always typical of a primary coronary event. And second, the often rapid resolution. It usually resolves spontaneously within just a few minutes, often without needing any specific intervention. And importantly, subsequent cardiac enzyme lab work will show no rise in troponin, confirming the absence of actual myocardial injury. Atropine might be given if the bradycardia is severe, but it's rarely required. However, the critical point is, if the ST elevation persists beyond a few minutes or isn't associated with those vagal signs, the operator must immediately pivot and aggressively rule out a true embolic event, either air embolism or thrombus, and treat that potentially life-threatening condition accordingly. You can't just assume it's the reflex if it doesn't fit the pattern.
Okay, finally, let's talk about a relatively common consequence of high-volume TSP, especially after using very large devices. The iatrogenic atrial septal defect, or IASD.
Yes, this is actually a frequent post-procedure finding, almost expected to some degree. Anytime you pass a very large bore sheath across the septum, and especially if you perform balloon dilatation for procedures like TMVI, a small residual hole or defect is often left behind in the fossa ovalis. The source notes that the size of the guiding catheter used during the primary procedure is probably the strongest predictor for how likely this iatrogenic ASD is to persist long term.
When does this leftover defect actually require active closure? Can it just be left alone sometimes?
It can often be left alone, yes, particularly if it's small, and echocardiography only shows a minor left to right shunt, blood flowing from the higher pressure left atrium to the right. However, closure is generally indicated if follow-up echo shows a significant shunt, specifically if there's any bidirectional shunting, or worse, a net right to left shunt, or if the defect itself is anatomically large, typically defined as greater than 8 millimeters in diameter. The primary risk associated with a persistent right to left shunt is that venous blood clots, which might form asymptomatically in the legs or pelvis, can now cross the hole directly into the systemic arterial circulation. This is called paradoxical embolism, and it can lead straight to a stroke or other systemic embolic event. So, if the operators decide on conservative management, not closing the defect, the patient absolutely must be placed on long-term empiric anticoagulation therapy to mitigate that serious systemic embolization risk. #outro.
Well, this deep dive has certainly shown that transseptal puncture is far from a single, simple step. It's really a meticulously planned and executed process that coordinates detailed anatomical checks, sophisticated equipment handling, multimodality imaging guidance, and immediate readiness for potentially life-threatening complications. The entire success of so much of modern structural heart repair seems to rest on this one precise entry point.
It really reinforces the essential, multifaceted training required for operators doing these procedures. The growing complexity of interventions absolutely necessitates TSP, and thankfully, the now mandatory use of TE Sidens has significantly improved precision and overall safety compared to the older blind techniques. But the authors rightly highlight that comprehensive training must cover the full spectrum, not just the technical stick skills to cross the septum, but also expert-level echocardiography interpretation and critically hands-on preparedness and simulation for rapidly managing a cardiac tamponade in real time. It's the whole package.
That leaves us with a provocative final thought for you, our listener, to consider. Given the rapid development we've discussed of specialized, non-needle-based systems, things like the controlled energy delivery of the Baylis RF system, and the inherent safety mechanism of the SafeSept guide wire, both of which are designed specifically to eliminate that dangerous overshoot risk inherent in scarred or difficult septa. Will the classic 60-plus-year-old Brockenbrough needle, which has been a cornerstone of this technique for decades, eventually become entirely replaced by these safer, more controlled, energy-based or specialized wire-based techniques, even for routine TSP access in the future? Something to think about. Thank you for watching The Funnel Effect.